So now we're going to do the discussion panel, and we have 4 wonderful participants here. Dr. Wagner, who we spoke earlier, and I don't think I need to reintroduce him. Dr. Madeleine Gagnon, she is the Complex Care Pediatrician and Associate Medical Director of Pediatrics at Gillette Children's Specialty Clinic, or Health Care in St. Paul. She's involved in care of patients with conditions including anoxic brain injury, cerebral palsy, global development delay, gastrostomy tube dependency, and genetic conditions. Dr. Gagnon went to medical school at Georgetown University in Washington, D.C., and completed her residency at Children's National Medical Center in Washington, D.C. She is a member of the American Academy of Pediatrics, American Academy for Cerebral Palsy and Developmental Medicine, and previously worked in complex care clinic at Boston Children's Hospital. So let's welcome Dr. Gagnon. Next to Dr. Gagnon, we have Emelia Rogers. Emelia Rogers received her master's in social work from Augsburg University in 2006. Remind me to talk to you. I have a friend who works there, and let's see if you'd like her or not. Economics professor is a good friend of mine. And she worked as an outpatient social worker at Gillette Children's Specialty Healthcare for the past 10 years. Emelia has special interests and focus on working with patients and families with neuromuscular conditions, and spearheaded a pilot program regarding transition. So let's welcome Emelia Rogers. And on the end, we have Kathy Lindstrom. Kathy Lindstrom is a family nurse practitioner at Gillette Children's Specialty Healthcare in St. Paul. Here, she specializes in rehabilitation medicine for conditions including cerebral palsy, neuromuscular disorder, and spina bifida. Kathy is a member of the American Academy for Cerebral Palsy and Developmental Medicine and Sigma Theta 2. So let's welcome Kathy Lindstrom. So as part of the registration process, I think we sent out an email asking for people to submit some questions for the panel discussion. So we surveyed 100 participants, and the top 4 answers are on the board. Do you have any name? We're not doing Family Feud here. Okay. So some of the questions have been asked. The first question has kind of been addressed, but maybe we want some more discussion on this. What defines successful transition and what doesn't? Or when is it not successful transition? So how would you like to define successful transition from pediatric to adults? It's hard.
Well, I'll start. I represent the pediatric side of things for folks at Gillette. And our complex care clinic, necessarily does not have an end date by which you have to age out, and we partner with our adult colleagues here who are here today. But in my view of what is successful in that transition piece into the adult years is quite similar to our goals in pediatrics, and that's being in your home community, thriving, being a part of an active job coaching, job placement, day programming, having a satisfying day experience, living in a place that is inclusive and where your care needs are being met and is safe. And those things sound very basic, of course, but we all know that that's a challenge, right? To find inclusive housing and accessible housing and care where our basic needs can be attended to and well funded, as well as providers who are comfortable with us. And so that's a huge goal of my relationship with, for example, these 3 other people right here is just all about relationship building in the very young years and adolescent years. Not within Gillette, certainly that's a given, and not necessarily with folks like PHS, but beyond that, finding folks who traditionally aren't as comfortable with our population, finding adult medical providers, finding adult social workers, finding adult nurses who are very intimidated by G-tubes and trachs and ventilators and diapers, and how do we help educate them and broaden that advocacy experience. And for example, when I'm working with an adult GI doctor and my question is perhaps about the G-tube feed or about some liver problem, I often have to be as simplistic and say, I want you to look beyond or look aside from the disability. Let's not let the spasticity or the wheelchair frighten you and intimidate you. I need you to just look at their liver function and help me better understand their liver disease, and not let that be a bias factor. And so trying to just truly be an advocate, as I would just for if I was trying to move through an IEP, or if I was trying to get an accessible housing grant. I mean, just the same approaches I take with those social pieces, I take with other doctors, just to help demystify some of these fears about this population, and find, I don't want necessarily someone who just is willing to take someone with disability. I want a provider who's really strong at their discipline, who's a really good gastroenterologist, and is going to provide really good GI care just as they would to anybody else, and not exclude or dismiss or fear people that I'm really excited and passionate about. So that's what I would define as a successful transition, is having your basic needs met and feeling good about it.
So from my perspective, I look at the patients and families that I see in the transition clinic, which we launched about 4 years ago. So I have a somewhat of a narrow perspective focused on that appointment type. As soon as those folks are scheduled to see me, we do an extensive chart review. So by the time they walk through our front door at Lifetime, we know a lot about them. Most of them are terrified when they come. I think Pat mentioned that in her speech today, that she was fearful. It's hard to change providers. It's hard to go to a new building. People are very uncomfortable and they're terrified. I had one dad in particular that brought his daughter in. She had spina bifida. He was an electrician. He was a big, tough guy. Took 6 months to get the appointment set up. He came in, checked in at our registration desk, turned around and walked away. He went home. He just couldn't face the appointment. He struggled talking about transition topics with his daughter. He didn't want to let her go. He didn't want to admit that she was growing up. We did get him back about 6 months later. He said to me initially, I have 15 minutes to spend with you, and then I'm leaving. He ended up staying a full 2 hours. So it was a very long, successful visit. So from my standpoint, when I'm looking at a successful transition, I'm focused on that appointment type. You have to get the families comfortable. You have to get them to trust you. We do the appointment in a conference room, not an exam room, so it's less intimidating. I don't have a computer in the room. A lot of one-on-one FaceTime with the family and the patient. We try to alleviate their stress as much as possible. They also get a tour of our clinic the minute they walk in the door, so they can see what we have at Lifetime. And it also makes that patient and family feel very important. They know our focus is on them and making them comfortable. So to me, those are all things that represent a successful transition appointment.
Go ahead.
I feel comfortable talking about not successful transitions, because a lot of times the social worker gets involved and things have not gone well. When it comes to those pieces, I think that there are so many different pieces. An easy piece is there's transition to adulthood that we're trying to help a whole bunch of patients get through, and then there's also transition to a new clinic. And so those two different pieces can overlap, and they can be one's going really successfully and one's not. A lot of times we see when things aren't going well, when they show back up on the peds side after they've had a successful transition, or so we thought, over to Lifetime. And then we can talk through a lot of the other pieces of why things have felt comfortable over on one side versus the other, and how we get them back over clinic-wise. The other piece is that I think that we have quite a few patients who their developmental age is not the same as their actual age, and that's when I would see that sometimes the transition doesn't go very well, because we have rules and we have laws about when people transition naturally, and when someone doesn't fit into those, it's just a lot harder to navigate and to advocate, and so it involves a larger community and systems to bring those things together. So a patient from last week, they did vocational rehab all the way through, but then they still needed some more services, and now they're 26 and wanting to start looking at colleges and figuring out some of those pieces, and it just doesn't go it's just not as smooth. And so we all have to work a little bit harder to figure out, okay, these were the programs that you probably were going to start at a certain age, or somebody else would have started then. So how can we work with you to figure out and replicate that path just a little bit later? So those are some of the pieces when successful transition doesn't necessarily happen, or just in a timely order.
And I thought I turned it on. I guess I didn't. Is it have to turn on that? Did that work? Okay. I don't need to say very much more because of these very thorough answers. We've all agreed that this is relationship-based work and trust has to operate. I found myself developing a kind of a set of goals. I guess I seem to like goals. When I meet individuals and families for the first time, I propose that we have 3 goals for the conversation, because we're not going to do anything procedural in the visit. The appointment is dedicated to really a conversation, and I point that out. So the young person who might be afraid that I'm going to do something painful, I'm not going to do anything painful. What we are going to do is have a conversation, and we're going to get to know each other, and by extension, to trust each other. Number 2, we're going to exchange information. A lot of the information is going to be coming from you, because you know yourself and your situation really well, way better than I do, but I know quite a bit about the general lay of the land, and I might be able to offer some things that you haven't been told before. And number 3, having gotten to know and trust each other and having exchanged information so that we all have access to the same body of information, then we make whatever decisions need to be made. My experience for myself and for others is that we kind of settle, and when I remember to, we revisit those goals at the end of the visit and say, have we achieved this? And mostly we have. Sometimes it's tense, sometimes their fear does operate. Sometimes, we felt forced to come over here. Let's talk about that for a minute, etc. But when fear has been dispelled, and when the needs are met in a basic sense, which goes along with dispelling fear, that looks pretty favorable to me as far as successful transition.
Very good. Thank you. It kind of segues into 2 of the questions that we have on here. One of them, it's kind of been addressed a little bit in the discussion today, but I'd like to see what the 4 of you think about this. What age should families and nurses be looking to start into the transition process? So as care providers, we might identify that this is a patient that's going to be needing long-term care. When should we as care providers start talking to the family about it's time, you need to start looking? What's the ideal age, and then what are you actually seeing out in the field?
So I have a very strong opinion about this. What parent doesn't turn to their 4-year-old and say or ask, what do you want to be when you grow up? We all do it, and that's the beginning of the transition questions. You are focusing on the future of your child, and that's what we need to do for patients with chronic illness and chronic disease. We have got to start early. The research, and if you go to the gottransition.org website, and I know it's been referenced today, it's an amazing website. They do have a timeline there. Their recommendation is age 12 for more formal discussions by providers about the age of those discussions. But in my book, you can start early. Please start early. And all of you can help with that.
From a practical standpoint, I like to start out the conversations when, for our electronic medical record, we have this piece where we have a by proxy piece where because of Minnesota laws, that has changed some of the conversation about what parents are allowed to see in their child's medical record. And it's the first piece, I think, it's right about 12 or 13, in which parents are like, what do you mean I can't see something? And that kind of discussion continues on in a lot of different aspects. It's the same question that comes up when a parent wants to see their child's college grades and they're told they can't unless the child gives them or the adult gives them to them. And so those are some of like a practical piece in which it's starting to talk about how a child is going to hopefully be able to take on some of these roles that they're doing for them as they move into adulthood. And if they're not able to, that we're still going to go through this process of guardianship and some of those other things. And so from a practical standpoint, it's a really nice piece to kind of pause and talk through what changes as we're going through parenting.
From our practice as a pediatrician, many community pediatricians often, again, whether it's disability related or not, often, have kind of traditional goals that they have in their mind for their kids, what it'll look like when they get their driver's license and graduate from high school. And so there's kind of these traditional or norms that are kind of set forth in their head. And so I work with a lot of kids with more profound disabilities, both intellectual and physical. And so always kind of from the get-go, there's this continual new acceptance, reacceptance of different pieces, whether it's the G-tube, and then they're 5 and we need our first wheelchair, and then it's kind of like this tumble where just when they think their feet are under them, there's kind of a new acceptance of something new that they weren't expecting or catches them off guard. And especially I find that the guardians who are around, those of 8, 9, 10-year-olds often are feeling, sometimes they're self-conscious, they're like, oh my gosh, I should not be thrown off by this new technology or this new thing I need to learn to accept, but it's that process and that journey. And so kind of with that is transition. And so whether that's, the technical piece of the guardianship hearing or the next steps, a lot of that can come around just even the funding of how are we going to fund the long-term care for your loved one, or where will they live, or what if you, mom or dad, get sick and have your own long-term, or are the siblings involved? And those are, for us, for our parents, right, those are really hard things to look in the mirror and think about. And so, just kind of gently through different natural avenues, the national kind of complex care movement, we try to bring those pieces up because those, are kind of continual reminders of, well, this is a really long marathon sometimes of the care needs in that chronic care picture, where it's not just about transition, it's about how do we ensure their safety and high quality life, for the future beyond us as guardians.
I thought that I wouldn't have a comment, but apparently I do, and that is why are you laughing? The extended school system is a really big factor in transition, and in this work have only cared for adults. So when they get to me, they're generally, the youngest I think I've seen is maybe 16 or 17. More typically it's 18, 19, 20 plus. And those who have already exited the extended school system are struggling more than those who come to me or come to us. Certainly it's not just me. Come to us earlier as part of that process. Because when that goes away, that's a lot, and it's both a lot in practical terms, and it's perceived as, we used to have everything, and now that was pulled, and that was pulled, and that was pulled, and insurance is different, et cetera, et cetera. So I would prefer that people, now I know that's not the earliest age of coming, so a lot of that, I don't know what those conversations are, but I do know if they come before the end of the high school career, it's far better than if they wait.
Very good, thank you. Earlier in a question before us, you mentioned the transfer of information from one group to another. So we had a question that was submitted to us. What does the process of sharing electronic data look like in this transition process? Examples, EHR transfers, medical histories, patient portals. Do any of you have recommendations on the process of how to transfer various forms of data to other care providers or new care providers?
Well, one positive coming in the next 12 months are shared IS platforms. So there's new platforms coming forward where different hospitals that have Cerner systems, for example, will be able to see each other's information, as well as Cerner to Epic in the coming future. So there's just IS modalities that are coming. Now that's not the same as if someone has eClinical works in their clinic, right? That's not going to overcome that barrier. But certainly between institutions, major hospitals in the local areas, just cross communication and viewing options is incredibly important, because one thing may be done in one system that's not done in another, and it's hard to fact check that or see results. So from a simplistic IS answer is, I think that's only improving, so we're really excited about that in the Twin City community. But also a lot of that just comes down to good communication and handoff, specifically, obviously, from my end on a physician end. I can think of a number of adults who continue to see us in the complex care transition piece with these folks, whereby I'll give the University of Minnesota, for example, we start to go down that list. Okay, who do you need for pulmonary? Who do you need for cardiology? And it's very, communication is important, obviously, in all relationships. And so, calling up that cardiologist, asking them, do you recognize that you've been appointed to be the adult cardiologist? How do you feel about that? This is who their pediatric cardiologist has been. Now, I understand that I'm not the cardiologist, but I feel it's really important to help kind of facilitate those pieces. Or we work with, med peds doctors or other primary care providers, so that provider and myself are kind of splitting that list and saying, okay, how do we help make these introductions between specialists, and where then, so long as the release of information has been signed, we can literally then be faxing medical records back and forth and helping facilitate that, which is a very manual process. But I think the manualness of it is probably a good thing. It's time consuming, but the good thing about it is it prompts phone to phone, at the very least, conversation, and saying, okay, now why are they on that medication, or what was your plan with that? Because a lot of this is nuanced medicine. There's not a textbook out there written on how to handle ... always for some of our folks. So the beauty of the hang up and the delay and manualness to it also provokes conversation, which I think is a good thing.
Mm-hmm. And when I see these folks for a transition clinic appointment, I put a clinic note together following that appointment. And my clinic note often serves as what's called a transfer package. And again, I keep referencing the gottransition.org website. There's a lot of information on what should be given to the patient so they can hand it over to a new provider. Many of the folks that I see are just now leaving their pediatrician, and they need to find a new adult provider. Our patients like to tell their stories, and the appointments can take a long, long time because they want to tell everything. So by having a transfer package available to the receiving provider, it's a much more efficient process. They can pick up my note, and I hope they read it. Sometimes I think they get put into a file drawer. It takes a long time to put these notes together, but it's really a synopsis of the patient, listing the providers that they've seen at Gillette, any outside providers that we're aware of, recent lab results. It just gives them a good picture of this patient. So it's a very important document. By record sharing electronically, that is going to save me an incredible amount of time, because it is time consuming to put all this information together. So.
Yeah.
Go ahead. Yes. Another concept that I bring up very often with folks, particularly in clinical care, but it's relevant here too, is pointing out that we make the best decisions we can based on the best information available. The clinicians in the adult community that are accepting into their practice a complex young adult who they know is going to stretch them, when they're willing, and these doctors, these clinicians, not always doctors, are willing, but they really don't know very much, they benefit tremendously from a body of information that's presented in a format that they can, there's the problem list, there's the meds, and here's why, this is great, wow, okay. Yeah, I feel very much better about this now. So, however that information is transmitted, electronic or health information exchange across computer systems, it's kind of sexy, it's kind of cool, and it's really efficient, and it's probably cheap, and it's faster, and whatever else, but it's machine to machine, and if we don't engage with the information itself and put that in front of all of us together and really review it together, that's completely theoretical. So I think it's a human issue. Yes, there's a technological piece, but it's a human issue primarily.
Very good. Thank you. So, a lot of our patients are very mobile. They go many places. They move away. They go to other geographic areas, even within the state. How would you recommend what makes a facility best suited to provide care for medically complex adults? So other than Gillette, which does a fantastic job, if a patient was moving to another geographic location, or even within cities and aren't able to go to Gillette, what would you recommend they look for in the medical provider, or the hospitals that are best suited for these medically complex young adults now?
I'll bet you have an opinion about that.
That's a good question. Certainly like anything, again, if you think back to their early childhood days or special education, it's all about a good advocate. And so, for example, yesterday there was an individual at Phoenix Children's who's older, adolescent years, and so kind of through a complex care national network this is on a provider front, that provider reached out to us saying, hey, this individual has cerebral palsy and they're coming up to the Twin Cities area and didn't know of Gillette, but knew of kind of some complex care work, and hey, do you know anybody who? Kind of, so like all things, right, if you're applying for a job, there's a networking. If you're a graduate from a certain college, there's a network. So kind of, so too, is there a complex care or a disability network that we often encourage folks to plug into. So often if someone tells me I'm departing, I'm going to either another state or another region, already in my head I'm trying to think of, okay, who else do we know there? Who else can we make that handoff to? It may not be that they're intimate with their actual care delivery, but they might just be another good advocate and resource. We think of when we've got someone who's in a local MedPeds program who needs to go elsewhere, we're trying to think of who else, near North Dakota do we know that has had other successful patients of ours. So a part of that is, again, comes back to our stewardship towards resource sharing, so and networking. And with that, then local advocate, there kind of often helps to open the door to other resources within that community. I mean, often that comes down to the individual self-advocacy skills and or their families or guardians, advocating on their behalf. And again, coming down to looking to providers who, again, whether it's a hospital system or an individual provider who's open and shares the same common life goals, as someone who has, unique and special needs and disabilities, who's, as we say, disability friendly, right? Who wants to think about how do we keep, have a good ER care plan for you and not just turn you away every time and say, I think you need to go somewhere else. Who's engaged and wants to learn more about you. I think, willingness to learn about you and your unique needs is the first step. Others?
I like that willingness to learn. That's a good question to ask the systems and the providers. So, what can the pediatric team, that includes the nursing staff, the D&E providers, the social workers, everybody out there, what can we do to ensure, the home-based team and clinic-based team, what can we do to ensure smooth transition to the adult providers? So maybe they're not going through the Gillette system, they're going through other systems. What can we do to help ensure this smooth transition?
I think that I spend a lot of time in clinic just helping families kind of unload the information that they have and trying to put it together in something that they can rattle off fairly quickly. And because, for the population in which they'll always have an adult caregiver, that sometimes the parents don't actually quite know exactly why they go to certain physicians. And of having some notes and like a very clear chart that can be put together at home that assists them to be able to have a good kind of transfer of care is huge. And some of that work can be done at home, and those conversations that you guys are having all the time, that organizational piece would be so helpful in the transition. And sometimes it's about creating charts so that if a patient is able to help to transition their own care and they're going to be going off to college and they have the same questions of, they know these providers, but sometimes they're not exactly sure who to call for what or when, making those charts together can be really helpful in that organization. And sometimes it's about practicing some simple things. So I have teens who will call me and leave these messages on my voicemail of like, I'm just wondering, even if I turn 19, can I just have my mom always call for the rest of my life to make my appointments, please? And so calling them back and saying, hey, like, I'm so glad you made this phone call. let's figure out a different plan, let's practice how to set up your own transportation, let's practice how to order a pizza, let's practice whatever that helps them just use the phone and feel more comfortable. And a lot of that practicing those skills, they need to be doing it in a lot of different environments so that it's not just to the one number, and of using the technology that we have with cell phones and everything else so that they feel really good about them doing the things on their own.
I think those are all really good points, and as home health nurses, you can play a really important part in helping educate these patients. I guess first talk to the family and the parents and very subtly tell them what you're planning to do so they don't get too upset with you. But teaching these kids about their medications, what are they taking? How often should they be taking them? What are they for? Can they explain their diagnosis? I'm always amazed at the number of people that I see in transition clinic, and I often ask the parent, it's usually the mom, to step out for a few minutes so I can have some private time with this patient if it's appropriate. And the patient often can't tell me what their diagnosis is, even though they're very capable of explaining it. They don't know. One patient, she thought she knew, but she was totally off base. It kind of blows me away. These are education pieces that should and can be done at home, and this is where all of you can really play an important part in that.
It reminds me of, so in starting a transition piece and pilot in the neuromuscular clinic, we realized as we were mapping out the different clinic appointments that kids are going to and then the parents are going to, and we realized that we do genetic counseling at the very beginning of the diagnosis, and so a lot of times the patients are 6 or 7, and so we realized that the patients themselves don't remember a genetic conversation and oftentimes weren't a part of it because it was talking about siblings or about potential children in the future for the parents. And so creating something in which, we need to have a genetic counseling appointment at the end before transition happens to adulthood. Those are the types of things that until you're mapping it out and talking it through, you're not thinking about those things. But those are the pieces, because now we're thinking about, for your kids, or what do you want to do in your planning? Those are the things that are, it can be really interesting and encouraging, and they can learn about things that they might have come to some conclusions that nobody said to them, but they had decided for themselves, and so we can help work on those pieces.
Mm-hmm. And I think with our very complex patients and families, these folks are struggling to get from one day to the next. They're struggling to get their young adult up and dressed in the morning and on the bus for school or to an appointment. The last thing that they want to think about is transitioning. They don't have time to think about it. It's not their fault. They are often so overwhelmed with the care that it's too much for them to think about. But I think Emelia brought up another good point, talking about what we call a care pathway, or the projection of the disease or the disorder. Many parents lose the focus on that piece. They don't realize that over time, with the teenage onset of hormones and growth, things can change pretty drastically. And they're focused on that care pathway that maybe they were educated about 10 years ago, 15 years ago, and they're not thinking about the future. So reviewing signs and symptoms. Neurogenic bladder, perfect example. The bladder can change, the musculature can change, whether it's due to hormones or growth. Most parents don't think about that. They don't realize that. So there are all these little nuances that we need to keep educating these folks about. And again, this is where home health nurses could play a huge part in this.
Very good, thank you. Many patients deviate from baseline. Knowing that, how do we talk to adult providers to ensure that our patient's normal is taken into consideration? Our patient's normal is not textbook normal. How do we talk to the new adult care provider about how our patient is normal, not their version of normal?
In my conversation with the parent I talked about earlier on the phone yesterday, she said, and I need to tell you this. I got really sick of people talking to me about my son's disabilities before they ever even thought to ask about his abilities. They clearly couldn't get to know him without knowing what his abilities are, but so they were predisposed to thinking about him in a certain way, which is entirely defined by disabilities. So that the exploration of that is at both a technical or clinical level. It's really important for me to know, are you able to take anything oral and to do so safely, or do I need to worry about you? And some parents say, oh yeah, he always coughs and splutters, he's always done that. Whoa, that makes me really nervous, because as you get older, that might get more and more significant, et cetera, et cetera. So I've learned to just ask. I have, kind of an intake document that I've passed out to some primary care colleagues and the occasional resident or medical student that I might run into. Here, it doesn't have a copyright on it. Do whatever you like with it, but it's a pretty decent way to frame up your understanding up front. And you'll find the questions uncomfortable to ask, but then you ask. Help me understand what you can do and what's hard for you. Can you do this all by yourself, or do you need some help? Do you need a lot of help, or do you really pretty much need your mom to do it for you, etc.?
Specifically with subspecialists, we really try to encourage them to not let the ICD-10 codes of what the disability is be a real barrier, because often it is. Again, I'm going to my adult pulmonologist and they see, vent dependent, they see CP, they see static and stuff. I mean, right there's a huge bias discrimination within the medical system, unfortunately, still, that therein lies, just there. The new referral has 3 ICD-10 codes on it, and right there, that provider may or may not, but unfortunately all too often, yes, is going to see that person on that piece of paper before the appointment's even scheduled in a very certain way. And so a lot of my job is to work with other providers, and I love working with adult providers because it's all the more challenging sometimes, to say, you've got to still see the pathology. I mean, they still have aspiration pneumonia, or they still have a cardiac problem, or they still have liver hemangiomas. They're still, disabled or not, cerebral palsy or not, we still need to look at this pathology. And so I really try to connect with other doctors on that pathology piece, because they're so well trained in pathology often, and it's their language, they can feel comfortable in that, and try to get them to feel comfortable in that, and saying, just because this person uses a wheelchair, or they're nonverbal, or they have 20 medications, is not a reason that you can't take care of them. If you don't want to take care of them, or you don't value their quality of life, or you have reigning judgments about their longevity and their well-being, that's a different situation. But most often, if we can get across that initial bias of just the codes and intimidation of the magnitude of usually their care needs, we can, connect with that pathology, and so trying to get them to go there.
I resonate with that piece when it comes to mental health, because we have a really difficult situation at times for someone to look past someone's physical disabilities and focus on the mental health. And it's that piece about comfort. It's about encouraging people, come and hang out at Gillette for a day, and everything, you get a different skew of what is normal. And I think that it's super important to just help everybody feel comfortable and use the language that they know. We're calling on you because you're an expert in this thing. So be that expert, and then ask a bunch of questions. And that can be really helpful. I think that also in the county and social service piece of things, that it's set up much like labels or ICD-10 codes, that you have to advocate based on the disability in order to get the services. So I'm coaching parents all the time of saying so at Gillette we talk a lot about cure pity. We're talking about people's abilities, but then when you are meeting with a county worker with Min Choices, you're going to have to focus a lot on the disability and talk about all the things they can't do in order to get the services. And so it makes those pieces where parents do have to switch back and forth, and they themselves that can be such an emotional roller coaster, because they're having to talk so much about the disability in order to get the services, and then they don't want their kids to hear that piece, because that's sending the opposite message of what they want. And so I think we talk a lot about within social work of like, so this is a one conversation that you're gonna have that doesn't focus really on your philosophy of how you're doing the caregiving, but it's what you need to do to get the services you need. And then let's help you figure out a way to structure your conversations with the providers so it doesn't go down that same path. And that it doesn't end up making it where you don't get the services you want. So, and I encourage nursing staff and social workers, anybody, you guys can always contact the social workers at Gillette and talk through like, here's a heads up, this is where a family's coming from. I won't be able to give you information if you don't have a release yet, but I can definitely take in the information and then figure out how we can help make some differences within a clinic appointment.
I order a lot of neuropsych or cognitive testing for many of the adolescents, especially those planning to go into a post-secondary program of some kind. And for several reasons, we need to identify where their abilities are. We may see a spina bifida patient that has executive function challenges, and it may not be appropriate for them to go to the University of Minnesota. They would probably struggle. And we can identify some of those concerns and issues with some neuropsych or some cognitive testing. It's hard to get parents to buy into that concept when I first bring it up, until I tell them that if their son or daughter ended up at the University of Minnesota, they spent $12,000 on tuition for one semester, and the child failed, their money goes right down the toilet. So at that point, it's pretty easy to pull the parents in and talk to them about the positive aspects of some testing.
I mean, those are the pieces that are talking about the real normal of parenting in general, right? We can talk about when it comes to American Idol or The Voice or whatever of like, are you going to let your kid who really can't sing audition for something? And those are the normal pieces of life that when we talk about all these pieces, it's all of our jobs to have those conversations of what we think about and what we hope for, what we dream for our own kids. And then, you know, if you're providing care for somebody in their home and you know their cognitive status, you need to have some thoughts about what they could do with their life and give them some opportunity to see those things in action. And that takes some brainstorming because it's not helpful if they have an IQ that's in the lower ranges to talk about them becoming a neurosurgeon, say. I mean, those are the pieces where we want those pieces to actually see some real foundational things that they could be doing in their future, because there's tons of things that they can do, and give them some opportunity to see those in action.
Thank you. This is a question that came to us in a few different forms, and it's very pertinent, or very timely. How do you advise handling situations where the patient and or their families are not happy with their primary adult care providers? We get that a lot. We have some of our long-term patients that are transitioned into the adult world, and they keep coming back to us and saying, help us, this isn't working. We're not getting what we need for me, meaning the patient or my child who is now an adult. Do you have any advice how we can help handle this?
Kind of similar to what I've said already many times over, is that again, it's about soliciting and eliciting. So agencies, whether it's PHS or Gillette, I mean, certainly we are agencies that have worked with a lot of folks with unique and special needs. So there's truly lists of resources and positive advocacy places. As I look at Dr. Barr over here, I mean, different, whether it's med peds clinics, about finding that fit, right? And so again, if a guardian and or an individual is continually going into a family medicine clinic or a med peds clinic or an internist, adult provider world, and it's feeling like there's not a connection, just as you would for your OBGYN or any other provider you see, or a therapist, if there's not a connection, or if you feel like they're not hearing you, just as you would in any other circumstance, you want to turn back and say, okay, what are the resources in the community? And those resources that have similar goals and visions aligned with mine, who do they use? Who do they refer to? And certainly there are, people always say, oh, but there's nobody. It just seems like nobody is willing to take us, or everyone is afraid of us. And, I certainly, feel that even personally, that I have a lot of fantastic allies in the adult community, specifically in the primary care world, of other providers who seem to be well aligned with how I view this world, and have a lot of patient satisfaction, because as I said, we don't necessarily, folks still come back to us as resource sometimes, and so we get that feedback. Oh, that primary care you connected with us is really, really good, and that worked for us. So we like to hear positive feedback, and Dr. Barr and her group has been awesome. So just as we would for anything else, we continue ongoing advocacy. Obviously, if there's snafus, road bumps, communication, right? If there's something that can be worked out with that original primary care provider, we encourage guardians and individuals to have good communication, but at the same point, it's philosophy. I can think of one family who has an adolescent who they just feel like, gosh, it just feels like every time I go to the primary care to get like the flu vaccine, they just kind of say, well, are we at the end of the road here? Is this it? And the child shame on me, this adolescent is doing really, really well. I mean, thriving in their extended school. To me, the question was like, really? Like, where'd that come from? Like, that wouldn't have ever even crossed my mind. Like, I mean, you never know what's going to happen tomorrow for any of us, but I don't think you're at the end of the line clinically, And so just, again, maybe that provider just doesn't have the right philosophy aligned with this individual and their clinical diagnoses. And so maybe it's time to find other providers. And there are a lot of great providers out there, in this century era, that understand the progressiveness and all the abilities that people with disabilities have and can do.
There's a body of literature by an Australian called Lennox. It was probably in the early 2000s, and he developed basically a kind of a package of information, and then studied it, and then he patented his package and sold it to the state of New South Wales, I think so. And so he wouldn't tell you what his package was, but he was able to, his research demonstrated that getting primary care practitioners in Australia to accept into their practice patients with adults with intellectual and other disabilities was significantly enhanced by providing them with this collection of information. Now, one assumes that it's not going to be particularly mysterious. It's going to be a complex care plan. It's going to be a med list. It's going to be this and that. It's going to be a schedule for, here's what they're due for and all the rest of it. So that it, in my assumption, and having read the article, if you provide that clinician with a body of information that, again, helps them make those, good decisions and feel that they do know where to start, then that's a big deal. If the first visit is accompanied by no acute medical agenda or problem, but indeed you come there and the courtesy of providing them with some information and etc. Most clinicians, in my experience, will be receptive, and especially if you provide them with some backfilling of knowledge and skills. If they just aren't, if the attitude is wrong and it's not a good fit, you're probably not going to fix that. If you have the right attitude and they're willing to learn and work with you, excellent, even if they don't know very much, and I hear that a lot too. But if the attitude is wrong, I just think you have to find another person, and probably family parent networks. I don't know that PACER involves itself in that sort of thing, but these are disability-friendly practices, etc. I don't have another good answer.
That kind of summarizes this whole topic. We have a lot more to learn. We have a lot more to discover. We have a lot more collaboration to build on. And we have a lot, as you said, a lot more to learn about all this. There was a couple questions from Mark Siegel, and he wasn't able to stay, and this is a good way to kind of wrap this conference up. One of the things was they asked for Mark Siegel is that where are the best places to go when you're traveling? Because Mark travels quite a bit. And he says Washington, D.C. He said Washington, D.C. is a great place to go for the patients we work with. It's easily accessible, very interesting place. The subway system's great. It's very handicap accessible. He liked that. He also said if you care to venture across the big pond over to Europe, he said Berlin. He said Berlin is also a very good place. No, nursing students, home nurses sometimes get to travel. There you go. That one. There's applications, but no. And he said, then if your care provider is up for it, San Francisco. He said a lot of hills. He does okay in a wheelchair, but his care provider sometimes struggle a little bit. So. With that, we're going to wrap this conference up, and I really want to thank again the students and the faculty of Northwestern University for this fine facility and all the work they've done. I'd like to give them a big round of applause.